You have a male patient who underwent parathyroidectomy, and the patient also has a pancreatic mass. Your timer starts now. Could you please define hyperplasia?
All right, so hyperplasia is basically the increase in the number of cells in tissue or in an organ in response to a stimulus or any sort of injury.
And how many parathyroid glands are mostly affected in this patient?
4 in this case.
What is the microscopic picture of hyperplasia?
So the microscopic picture we divide into the most common and less common. So the most common we will see is chief cell hyperplasia, and less commonly we usually see water clear cells and some other forms of cells which include oxyphil cells in this case as well.
The patient develops stupor, confusion, hypoglycemia. Can you explain to me why?
So these are the most common symptoms which we usually see in insulinoma, which includes stupor, confusion, hypoglycemia, as in this case. So it's like, so this is due to insulinoma here.
What are other causes of unresponsive hypoglycemia or refractory hypoglycemia?
So other causes of unresponsive hypoglycemia could be abnormal insulin insensitivity in certain liver disease patients as well. Some inherited problems like glycogenesis and ectopic insulin secretions as well.
In terms of insulinoma, what is the clinical picture of insulinoma?
So the clinical picture of insulinoma is hypoglycemia, which we usually will see hypoglycemic symptoms, some central nervous system symptoms like confusion, stupor, coma, and even at some point unconsciousness as well.
Do anything else? You want to focus on the web.
Sorry, yeah.
How would you diagnose insulinoma biochemically?
So biochemically, we will check for insulin to glucose ratio, plasma insulin levels, plasma C-peptide, and also proinsulin levels as well.
What are the 3 gene mutations you can see in insulinoma?
So the 3 gene mutations we will see is menin gene, which we see in multiple endocrine neoplasia type 1, loss of function of basically tumor suppressor gene like a PTEN and TSC2, and DAX and ATREX gene as well.
Well done. Any other pathology that you might suspect in this patient?
So this patient is having MEN1, so we will suspect to this patient having a pituitary adenoma as well.
Not necessarily. It's something that you suspect. It doesn't mean that they have it. All right. What is a double hit hypothesis?
So double hit hypothesis is for a tumor suppressor genes. Basically, it acts in a recessive manner, which means that both alleles should be basically affected to progress towards cancer.
Right. What is a telomere?
So telomere is a repetitive sequence which is located at the end of each chromosome. Basically, it protects the chromosome from fusion.
Right. You have a female patient with thyroid nodule and elevated calcitonin level. What is the single best test to diagnose?
Fine needle aspiration test.
You're referring to a biopsy, so fine needle aspiration and cytology, right?
And cytology and immunohistochemistry as well. Yeah.
Correct. So these are the key points to mention, the cytology and immunohistochemistry, because the needle aspiration in itself is not diagnosis. We've done the fine needle aspiration and cytology, which showed malignant cell features, amyloid deposits, immunohistochemistry stains positive for calcitonin and stain negative for thyroxine. What is the type of cancer that you think of?
Medullary cell carcinoma of the thyroid.
And why is that?
Because of the amyloid deposits and calcitonin.
That's right. And what is the cell source or the cell of origin for this type of cancer?
So it's parafollicular C cells.
Well done. What is immunohistochemistry in very simple words?
So immunohistochemistry is basically looking at the specimen under the microscope. So what happens is the antibody localizes the antigen and then it binds to the antigen. And then we see the specimen, basically the type of cells or antigen under the microscope.
And how does it work?
So it works like, as I mentioned, the antibody will basically localize the antigen and then it will attach the primary and the secondary and antibody will attach to each other. And then we will observe the specimen under the microscope to localize the type, the intensity of the specimen.
I can corner you in that question, right? I wouldn't do that now, but your answer is incomplete. Because you said some words that the examiner can use sort of against you and start asking you further questions. Anyways,
sorry,
I'll come back to it at the end of the feedback.
Once again, can I mention a few things more about immunohistochemistry?
Yeah,
that's all right with you. So once the antigen is localized, so basically there is a fluorescent dye that will be activated and that we can see under the microscope to localize basically the specimen and type of cell.
What is the type of antigen-antibody reaction in immunohistochemistry?
It's a complement fixation here.
If this condition is familial, what other conditions can you think of?
So other condition I can think of in this case would be pheochromocytoma. Sorry, I'm not quite sure about this.
What are the types of MEN syndromes and the oncogene mutations and the mode of inheritance?
So there are two types of MEN syndromes, MEN1 and then MEN2. We further divide in MEN2A, MEN2B. So it's an autosomal dominant mutation, and one is basically has a gene mutation in the chromosome 11.
So if the condition is familial, you wouldn't think about parathyroid hyperplasia as well, because this is part of the differentials. You can also think of the pheochromocytoma and the morphotic features, which is fair enough. Treatment of medullary thyroid cancer.
So treatment usually will be discussed in the MDT meeting, and then possibly will be basically total thyroidectomy and with block neck dissection.
Good. I think we still have 8 seconds, which is almost done. And we've covered everything. So that's well done for coming to the end of the scenario. It's a fairly long scenario. I don't think I have so many feedback for you, just a few things. I think you've made the answers short and to the point, which is great. You're not going around in circles and trying to give me more words, but you've made the answers clear and to the point and exactly what the examiner would like to hear. All right. In most of the questions, the only thing is clinical picture. Just mentioned Whipple triad, hypoglycemia, neurological symptoms. The key point is the immediate relief of symptoms after administration of glucose. All right, and how would you diagnose insulinoma? You've answered this well, and you've said the genes, which is great as well. The double hit hypothesis, you can explain further to that, all right? You can say that for each cell in the body, it has 2 tumor suppressor genes. Each cell, it has 2 tumor suppressor. You said the 2 alleles has to be affected. Well, what are you referring to? I wasn't sure what are you referring to. So it has 2 tumor suppressor genes in each cell. So for a cell to be cancerous, the two genes need to mutate. Or the 2 genes has to be knocked down, has to come out of the picture. So it will lead to a loss of function mutation, which is recessive in nature. Telomere, you've answered it very well. N2, I think overall very good. The only thing I would mention, the immunohistochemistry, you want to say it's a method of localizing a specific antigen in the body through antigen-antibody reaction. So you want to identify certain antigen by antigen-antibody reaction. How does it work? So you take a sample, you get an antibody, you connect the antibody with a fluorescent dye or an enzyme. Once the antigen interact with the antibody, you will have an antigen-antibody reaction. The enzyme will be activated and the fluorescent dye will appear under the microscope. Very simple. Here you started saying, well, we do that. And I wouldn't use the term we do that unless you actually do it. All right. So just explain it the way you know it, because I don't think that you've ever done immunohistochemistry for anyone. I personally have never done immunohistochemistry. I don't know how it's done. I haven't seen it before. I've only seen some videos, right? So I wouldn't refer to that we do that and we do that. Well, we don't do it. Anyways, antigen-antibody reaction to complement fixation, but otherwise I think was very well the rest of the questions. It's a straightforward scenario. You can make it difficult for yourself if you start trying to give difficult answers, but just make direct answer to the points, and that's pretty much it. All right.
Thank you very much for the feedback. Thank you. Really appreciate that. Thank you.
All right. Next, Pranthi.
Yes. Am I audible?
I can hear you well.
Yeah.
All right. You have a patient who's going bilateral nephrectomy due to intractable abdominal pain, and after the nephrectomy, you can see this. What is the gross pathology that you can see there?
I can see a bilateral enlarged kidneys with multiple cysts and areas of hemorrhage and necrosis.
What's the mode of inheritance of this condition?
It is inherited in an autosomal dominant pattern. So I was about to say that it is due to the mutation in the genes PKD1 and PKD2.
I know I've written this in the answer. To be honest, I wouldn't provoke the examiner. I would just say autosomal dominant and stop there. All right. What's the pathogenesis of cyst formation?
So the pathogenesis is first whenever there's a mutation in the polycystin 1 and 2. This will lead to the abnormal proliferation of the tubular epithelial cells. And second process being the outpouching. So because there's excessive growth, it will form a saccular outgrowth from the actual structure. Then next is the expansion. So what happens is because of the saccular outgrowth, it will pinch out and become an isolated cyst. Next being the destruction. Because of the growth of the isolated cyst, it can cause compression of the renal parenchyma and cause destruction.
And other organs that can develop a cyst as well in this condition?
It can be the liver, the spleen in this condition. And
what are the complications of this condition?
The complication is first one being the hypertension because of the compression of the renal parenchyma. There can be infections. Then in chronic condition can go into renal failure.
What are the associated brain lesions in this condition?
It's associated with cerebral aneurysms.
And what is the type of matching in renal transplant?
First one being the ABO matching. Then you do the HLA matching, which includes the HLA A, B, and the R, which is most important when you're considering a transplant.
What are the types of graft rejection that
So there are three kinds of graft rejection. First one being the hyperacute. So this happens immediately, and it's a type 2 hypersensitivity reaction, where there are preformed antibodies against the donor ABO or HLA. And the treatment for this is you will have to remove the transplanted kidney. Second one being the acute transplant rejection, which usually happens in about 7 days. This is because of the T-cell mediated reaction against the major histocompatibility complex. And this can be treated with immunosuppressants. Chronic rejection can either happen after 6 months to a few years. This is again T-cell mediated and antibody mediated. You can appreciate fibrosis and scarring of the renal tissue.
What are the type of malignancy that could happen in immunocompromised patients?
Immunocompromised patients, I would consider squamous cell carcinoma, Kaposi sarcoma, lymphoma, and basal cell carcinoma.
All right, well done. So again, I really like that. Very straight and to the point, and not fiddling around. So that's great. The only thing to mention, the complications, you want to focus on renal failure, infection, and hypertension. These are the buzzwords that you actually need to mention there. Other organs that can develop a cyst, you can also mention the ovary and the pancreas. You mentioned liver and spleen.
I thought you asked in this condition, so I was, okay.
Ovaries and pancreas can also develop cysts in polycystic kidney disease. Any organ in the body can have cysts, right? Any organ in the body can have cysts. But in polycystic kidney disease, you get the liver, the ovaries, the pancreas, and the spleen. The pathology, you just try to highlight your words, right? Because I think I got lost a little bit when you were answering it. I'm sure you've covered it well, but you want to just highlight what you're talking about. You want to say it starts by inactivation, then outpocketing, then expansion, then isolation and growth. The inactivation, which is related to the renal tubule cell, will divide repeatedly after inactivation of the polycystic kidney gene 1 and 2. Outpocketing, this will basically, division will continue until you form a saccular cyst that outpockets from the tubules. The expansion, it will keep expanding and then it will be fluid filled. Isolation of the growth, under reaching certain size, it will be completely isolated from the tubules and it will form an independent fluid filled cavity that is called a cyst. All right. So you just want to highlight the keywords that you're saying to your examiner so that they're able to follow what you're saying, especially when you have a quite long answer like this one. All right.
Yes.
Good. I will give you that scenario as well. You have a 60-year-old female patient presented with headaches, skull tenderness, and the temporal side specifically on mastication. She also reported transient loss of vision. The temporal artery biopsy was taken later and revealed giant cell arteritis. What is giant cell arteritis?
So it is the inflammation of the medium and large vessels. Here mainly involves the branches of the carotid artery. So if it involves the ophthalmic artery, it can cause blindness. If it involves the temporal artery, it can cause unilateral headache. And if it involves the maxillary artery, it can cause painful mastication.
Which vessels are usually affected?
The most affected is the temporal artery.
And describe the pathological changes in the following picture. You will be given this picture and they will be asked to describe the pathological changes.
So here you can see that there's intimal wall thickening and the lumen is obliterated. And also you can see areas of granulomas. That is, in the center, you have macrophages and multinucleated giant cells, which is surrounded by T lymphocytes.
We're going to come to this. I'm just going to leave that question for now. What's the initial test that should have been done in this patient?
Is ESR.
What is ESR?
It is how fast you take the patient sample and you see how fast the RBCs are able to settle down.
And how is it done?
So you draw a patient's blood in the Western Cards vertical tube, and then you leave it for about 1 hour. And then you measure the vertical distance between the surface of the blood till the sedimented RBCs.
And what is the best test to diagnose this condition?
You will have to take a temporal artery biopsy.
How does blindness happen in this patient?
Blindness is whenever the ophthalmic artery is included in the inflammation, it can cause narrowing and cause ischemia, so blindness.
What is the treatment for this condition?
So it's a medical emergency. So you'll have to immediately, once you're diagnosed, you'll have to give oral prednisolone, that is 60 mg orally. And if there is any visual problems, then you should consider giving IV methylprednisolone.
All right. So blindness happens basically involved with the ophthalmic artery and sometimes a blood clot that's going to the ophthalmic artery, which basically is the blood supply for the optic nerve. And it will lead to a condition, and you need to say that in the exam, anterior ischemic optic neuropathy, the iron. All right. Otherwise, I think you've answered everything straight into the point. The histology, you want to focus on certain things. 1, intimal thickening. 2, granuloma formation. 3, presence of the macrophages, etc. And narrowing of the lumen. These are the 3 key points that I will summarize here. I know the answer is extremely long, but what I'm going to say, intimal thickening, narrowing of the lumen, and the granuloma formation in the wall, which you're referring to. I think that is pretty much it. But blindness can happen to blood clots going into the ophthalmic artery or involvement into the ophthalmic artery. The ophthalmic artery supplies the optic nerve, and this can lead to iron, right? Anterior ischemic optic neuropathy. Cool. You have a female patient who presented following a road traffic accident. She is known to have sickle cell anemia, and she has headache. She has a head CT done and showed a temporal mass measuring 3.8 centimeter, which was incidentally discovered. What is the definition of sickle cell anemia?
Sickle cell anemia, it is an hereditary hemoglobinopathy where there is formation of hemoglobin S, which will distort the shape of the RBC from biconcave into sickle shape.
Okay, what are the complications of this condition?
The complications include vaso-occlusive crisis, aplastic crisis, and infection, splenic sequestration. Should explain deep into the vaso-occlusive.
No, that's fine. What is the mechanism of autosplenectomy in this condition?
Autosplenectomy, the sickle cells, they obstruct the microvasculature, leading to areas of infarction in the spleen. So multiple episodes of infarction, it leads to autosplenectomy.
What are the surgical relevance of sickle cell anemia?
Surgical relevance, one is gallstones, pulmonary hypertension, autosplenectomy, and then vaso-occlusive crisis.
And why is this patient immunocompromised?
Why is this patient? Because of infection by encapsulated organisms. Post-autosplenectomy, there could be infection by Streptococcus pneumoniae, Haemophilus influenza, and Neisseria.
So with regards to the patient having a temporal mass, what are the brain cells or the divisions of the brain cells that?
The brain cells are astrocytes, oligodendrocytes, and neurons and ependymocytes.
What are the causes of brain tumors?
The brain tumors can be classified as primary and secondary. Primary brain tumors arise from the cells in the brain like astrocytoma, oligodendrocytoma, meningioma, and acoustic neuroma. Whereas secondary, they arise from metastasis from organs like breast, lungs, etc.
What are the most common types of brain tumor?
The most common types, we divide it as high grade and low grade.
What is the commonest tumor in the brain?
Commonest tumor in the brain, is it?
No.
I'm sure that one, sir.
What's the clinical presentation of brain tumors?
They are general manifestations In general manifestations, there will be headache, nausea, vomiting, seizures, and then increased intracranial pressure, which leads to papilledema. And then, depending upon the location, if it is in the frontal lobe is involved, it can lead to paralysis as well as personality changes. If temporal lobe is involved, it can lead to contralateral upper quadrant anopia and then aphasia. If lobe is involved, it is contralateral inferior quadrant anopia and dysarthria.
Okay, what if you left this tumor untreated?
If tumor is left untreated, tumor will herniate and then it will compress the brainstem, compressing the respiratory center, leading to
How would the tumor herniate?
It would herniate through tentorium.
Tumor.
I do not know of this ones.
Okay. The biopsy taken and that showed squamous cells. Could you explain what could be the reason?
It could be due to metastasis. There could be a squamous cells in the brain.
The patient had wound infection on the biopsy. What's the commonest organism for wound infection?
It is Staphylococcus aureus.
And the wound had a child that has some glucose in it. What could be the reason?
It could be due to cerebrospinal fluid could be present. It could be a communication with the CSF. Very
good. All right. Thank you very much. You've pretty much answered everything. If we go back to sickle cell anemia, so definition, it's a hereditary hemoglobinopathy caused by point mutation of the beta globin. And you want to talk about the shape of the cells and the effect of that. It usually promotes polymerization of deoxygenated hemoglobin, and it will also replace the glutamate with the valine and also form the hemoglobin S and leads to anemia. With regards to complications, I know you asked that question, but I think it's worth giving a single word about each complication, because just naming them, it doesn't really mean anything, right? So you want to say vaso-occlusive crisis, and this can be triggered by infection, dehydration, or acidosis, and it can lead to bone or lung or brain or spleen issues, including a stroke or cut of the blood supply. Sequestration crisis is massive entrapment of sickle cells into the spleen. Aplastic crisis, which is a pancytopenia caused by parvovirus B19. Chronic tissue hypoxia and organ failure, including heart, spleen, kidney, etc. And increased susceptibility to infection due to autosplenectomy. The mechanism of autosplenectomy, here you're focusing on the initial engorgement or entrapment of lots of cells inside the spleen, leading to red pulp congestion. And then on the long term, this issue will happen multiple times during childhood, and this will lead to splenic fibrosis, infection, and the progressive damage of the spleen. The surgical relevance of sickle cell anemia. Yes, you would like to mention the gallbladder or gallstones. However, autosplenectomy, vascular necrosis, osteomyelitis, pulmonary hypertension, and heart failure are also relevant and needs to be mentioned. And of course, the risk of bleeding as well in sickle cell anemia is relatively high and also needs to be mentioned. The patient is immunocompromised, and because mainly due to autosplenectomy, and this is increased risk of encapsulated bacteria. They are not immunocompromised because they have encapsulated bacteria, but it's because they have autosplenectomy. And the answer that you've given was encapsulated bacteria, and that's not the answer. The types of cells in the brain, you have multiple different types, astrocytes, oligodendrocytes, which you've already mentioned. The tumors could be primary and secondary. Most common type is metastasis, but you can also classify them into high grade and low grade because this is asking types. But when I ask you what is the most common type of brain tumor, it is the metastasis. The clinical presentation, I think you cornered yourself really here in this question, and you would like to give more of a general approach to the symptoms of intracranial issues and not necessarily going through each lobe and trying to tell me what happens, or basically trying to tell me what you remember, which in most of the times will be inaccurate and incomplete. What I would like to mention here, this patient has a brain tumor. They are at risk of having increased intracranial pressure, and they will have all the symptoms of high intracranial pressure. And this includes headache, blurring of vision, nausea, vomiting, and confusion that can move into stupor and loss of consciousness and even sudden death. They can also have focal neurological deficit in the form of motor or sensory deficit, or even something like seizures. I think that's pretty much it. I wouldn't necessarily go, well, if the temporal lobe is involved, this will happen. If the frontal lobe is involved, this will happen. If the parietal lobe is involved, you can do that as a single example, right? But you don't have to go through each loop and try to tell me what happens. You just want to say general symptoms or general signs due to increased intracranial pressure and focal neurological deficit in the form of motor, sensory, or seizures or anything else like that. All right. If the tumor left untreated, the tumor will not herniate. The brain will, because you can have a brain tumor all the way high up into the parietal lobe, right? And the tumor will not necessarily herniate. It will not necessarily metastasize, but the brain will herniate. And this is what leads to death. Biopsy was taken, sickle cell, squamous cell cancer. Well, the brain doesn't have any squamous cells, and therefore this is very likely metastatic. And the metastatic squamous cell cancer could happen from the skin and the openings, right? The skin, nasopharynx, oropharynx, the lung, the esophagus, the cervix, the anal canal, all of this can go to the brain. And you've answered the last two questions well. Do you have any questions?
No, sir. Thank you. So this one, mainly the manifestation of brain tumors, I can tell it like it can result in increase in the intracranial pressure and associated symptoms.
Correct. All right. Last scenario was Mustafa, please.
Hello.
Can you hear me?
Yes.
You have a female patient who is known to have hypothyroidism, presented to the GP with right inguinal swelling. The GP sent her for pathology. What's your differential diagnosis for inguinal region swelling?
Different diagnoses include hernia, abscess, lymph node metastasis, and also sophonex varix.
Varix, rather. All right. What's your differential diagnosis for enlarged lymph nodes in the inguinal region?
It can be infective or metastatic. Infective include venereal infection such as HSV, syphilis, and sarcoid, and metastases include melanoma or other metastases.
Answer here is a bit incomplete. So malignancy could be primary. Melanoma is not necessarily metastatic, but the malignancy associated with inguinal lymph nodes could be primary, such as lymphoma or leukemia, and secondary, which could come from any area in the region, the testis and the scrotum. And the infection associated with lymph nodes, including cellulitis and also neural infections such as chancroid, right, and syphilis and lymphogranuloma venereum, etc. The draining area of the inguinal lymph nodes.
It drains the whole lower limb, the skin, the lower abdomen, and also renal and genital region.
And why the result of final aspiration cytology was not satisfactory? Could you think of any reason?
Because of adequate tissue aspirated and inadequate tissue, and because of lack of ultrasonography guide.
Skin condition that could be associated with melanoma?
Skin condition, sure.
What are the risk factors of malignant melanoma?
Risk factor of malignant melanoma is previous history of melanoma, sun-exposed area, I think, and scientists. I remember just.
What comments would you look for on the pathology report?
About melanoma, I'm looking for the soft tumor, the thickness of the tumor, and also the invasion to blood vessels and the margin of the tumor.
What comments, difference between malignant melanoma and squamous cell carcinoma, please?
Difference between malignant and squamous cell. Squamous cell arises from two upper layer of the epiderm, but the melanoma arises from the lower layer of the epiderm.
What is a satellite lesion?
Satellite lesion, you can see around the primary lesion in 2 centimeters around it in the line of lymphatic drainage.
What is epithelioid?
I'm not sure. I don't.
What's the poor prognostic factors in malignant melanoma?
It's about the depth of the invasion of the tumor, increased depth of the invasion, and also very slow thickness. It's, I think, increased number of mitosis